Hey everyone, welcome. It's us here at Book Podcaster. And look, if you're maybe feeling a bit snowed under right now,
Mhm.
maybe your brain feels like it's got, I don't know, 50 tabs open, especially if you're, say, wading through healthcare studies, like a friend of mine who's a nursing student, can feel totally overwhelming, right?
Yeah.
We get it. It's like trying to learn a whole new language sometimes. But today, we're going to take a breath and do a deep dive into something really fascinating. We're exploring that connection between mind and body, specifically looking at somatic symptom and dissociative disorders.
Exactly. It's this idea that, when emotional pain gets really intense, it doesn't always just, well, feel emotional. Sometimes the body kind of takes over the signaling, showing up as physical symptoms, or our conscious experience, our memory, even our sense of who we are can get disrupted.
Right, like the wiring gets crossed somehow. So our goal today is to unpack that a bit, to
Yeah.
really understand these conditions, and crucially, especially for those of you heading into caring professions, to see the massive role that connection, compassion, and just seeing the person really plays.
Yeah, we've been looking at the research, including, key texts like Townsend's Psychiatric Mental Health Nursing, to really distill the core ideas. So we'll talk about the two main categories, maybe touch on why these things might happen, treatment ideas, and definitely assessment and nursing support. We even have a sort of case example to illustrate it all.
And here's the really big takeaway up front. When someone is experiencing these symptoms, even if all the medical tests come back clear, what they are feeling is 100% real for them. It's not imagined. Okay, so let's get into it. When we say somatic symptom and dissociative disorders, what exactly are we talking about?
So at their core, these are conditions where emotional distress kind of gets expressed differently. With somatic symptom disorders, it's primarily through physical symptoms. Think pain, fatigue, stomach issues, things that make you think I need to see a doctor, but without a clear medical cause. Dissociative disorders, on the other hand, involve disruptions in consciousness, memory, identity, how you perceive things, like a break in the usual flow.
A break in the flow. I like that. And just to double click on something important you mentioned, this isn't about people faking it, right?
Absolutely not. That's a common misconception, but it's really unhelpful. The suffering is genuine, the distress is real, even if the origin isn't purely organic or easily identifiable through standard tests.
Got it. So let's maybe zoom in on those somatic symptom disorders first. What do they look like?
Okay. So, somatic symptom disorder itself, the main one, involves having one or more, often multiple, physical symptoms that are really distressing or disruptive to daily life. Think about, say, Rosa from one of the examples. She experiences chronic pain, serious fatigue. She's seen tons of doctors, had lots of tests, but nothing definitive pops up medically. It doesn't make her pain less real. It just suggests the driver might be linked to underlying distress expressing itself physically.
Right, the body's alarm system is ringing, but maybe for a different reason than expected. What about illness anxiety disorder? That used to be called hypochondriasis, I think.
Yeah, exactly. This one's characterized by a real preoccupation with having or getting a serious illness. It's way beyond normal health concerns. We all worry sometimes, maybe Google a symptom, but this is persistent anxiety, constant body checking, maybe seeking reassurance, but never really feeling okay.
Like the example of Devin, who's always convinced minor things are cancer, even when doctors say no. That sounds exhausting.
It really is. Then you have conversion disorder. This one's quite striking. It involves neurological symptoms like paralysis, blindness, seizures that can't be explained by any neurological disease.
Wow. So like the example of Jamal, who becomes temporarily blind after witnessing something really traumatic, there's nothing wrong with his eyes, medically speaking.
Medically, no, the visual pathways are intact. But the psychological trauma is so overwhelming, it manifests as a very real loss of function. It's a powerful mind-body link.
Okay. And how is that different from, say, factitious disorder?
Good question. With factitious disorder, the person intentionally fakes or produces symptoms. But, and this is key, the motivation isn't external gain, like getting money or avoiding work. It's usually driven by an internal psychological need to be in the sick role, to receive care or attention associated with being ill.
Ah, okay. Like Mary, who might inject insulin to make herself hypoglycemic just to be hospitalized. It's coming from a deeper psychological place. Right, that clarifies the somatic side quite a bit. Now let's switch gears to dissociative disorders. What's the common thread there?
The core feature is a disruption, a sort of fragmentation, in the usually integrated functions of consciousness, memory, identity, or perception. It's like the mind hitting an escape button, creating distance from experiences or feelings that are too much to handle consciously.
Makes sense. And the one we probably hear about most is dissociative amnesia. This isn't just like forgetting where you left your phone, is it?
Definitely not. This involves being unable to recall important personal information, usually something traumatic or stressful. The key is the extent of the memory loss and its direct link to that emotional event. It's not just fuzziness, it's often significant gaps.
Like Lewis, who couldn't remember the whole week surrounding a bad car accident. That specific traumatic period is just gone.
Exactly. Then there's dissociative identity disorder, or DID, probably the most complex and often sensationalized. This involves having two or more distinct personality states, sometimes called alters or identities, that recurrently take control of the person's behavior. There are often memory gaps between these states as well.
Right, the example of Anna, who has her main self, but also Leela and Marcus, who seem to emerge to handle different feelings or situations. And the sources often link this strongly to severe, often early childhood trauma, don't they?
Yes, that link is very well established in the research. It's often understood as a coping mechanism developed in response to overwhelming, inescapable trauma. And finally, there's depersonalization, derealization disorder.
Okay, what's involved there?
This one brings feelings of detachment. Depersonalization is feeling detached from yourself, like you're watching your life from the outside, maybe feeling robotic or unreal. Derealization is feeling detached from your surroundings. The world seems foggy, dreamlike, distorted.
Like Sandra feeling she's watching herself in a movie. That sounds really unsettling, that feeling of unreality. So we've got a handle on what these are, but why does they happen? What are the theories behind them?
Well, from a psychodynamic perspective, the idea is often about managing overwhelming emotions. For somatic symptoms, it might be seen as repressed anxiety or conflict getting converted into a physical issue because it can't be dealt with emotionally. For dissociation, it's often viewed as a defense mechanism, the mind splitting off parts of experience to survive trauma.
Kind of like an emergency shutoff valve for unbearable feelings. What about biological factors? Is there anything physical going on in the brain?
There's some research pointing in that direction. Things like potentially lower levels of serotonin, which we know affects mood. Also, possibly a more sensitive limbic system, the brain's emotional center. And maybe some differences in how the brain processes pain or fear signals. It's likely not one single thing, but probably an interaction between psychological vulnerability and maybe some biological predispositions.
And that quote from Townsend really seems to tie it together, doesn't it?
Yep.
That these disorders often reflect an inability to process overwhelming emotion through verbal expression.
Exactly. If the feelings can't get out through words or healthy coping, they might find these other, less adaptive pathways.
Makes sense. Okay, so knowing all this, how do we approach treatment? What helps people with these conditions?
For the somatic symptom disorders, a big one is cognitive behavioral therapy, CBT. That really focuses on helping people identify and change those unhelpful thought patterns about their health, their symptoms, their body. Also, things like mindfulness and stress reduction techniques can be really effective for managing both the physical sensations and the anxiety.
And I think you mentioned medications sometimes, like SSRIs.
Yes, especially if there's significant co-occurring depression or anxiety, SSRIs might be used to help manage those symptoms, which can indirectly help with the somatic complaints too. Another key thing, practically, is having regular scheduled appointments with one consistent healthcare provider.
Why is that so important?
It builds trust, first off,
Right.
but it also helps reduce that cycle of doctor shopping, going from specialist to specialist, seeking a purely physical answer. That can sometimes reinforce the focus on illness. Consistent care shifts the focus towards managing symptoms and improving function.
Okay. And what about for dissociative disorders? The approach sounds a bit different there, focusing more on trauma.
Yes, absolutely. Trauma-informed therapy is really the foundation. Therapies like EMDR, eye movement desensitization, and reprocessing can be very helpful, especially if the dissociation is linked to PTSD. Sometimes, carefully, hypnotherapy might be used, particularly in DAD, as part of a broader treatment plan. And universally, teaching grounding techniques is crucial.
Right, those techniques to help people stay present when they feel like they're floating away or disconnected. Can you give an example?
Sure, simple things like naming 5 things you can see in the room, maybe 5 blue things, or really focusing on the feeling of your feet on the floor, the chair supporting you, engaging the senses to anchor back into the here and now.
Those sound really practical. Okay, let's think about nursing now. If you're a nurse assessing someone, what are the key things to look out for?
Well, first, you'd listen carefully to the physical symptoms. Are they kind of vague? Do they shift around a lot? Are there inconsistencies with known medical patterns? Also, critically, how is this affecting their life? Are they unable to work, go to school, manage self-care because of these symptoms? That functional impact is huge.
And you definitely want to ask about trauma history, right? Gently, of course.
Absolutely. Assessing for any history of abuse, neglect, major losses, combat exposure, that's vital context. Then you'd also look at their cognitive status. Are there memory gaps they can't explain? Do they describe feeling unreal or detached, like that depersonalization or derealization? With potential DID, are there any hints of different identity states? And of course, how are they coping now? What strategies do they use? Any substance use or self-harm?
That's a lot to cover, but it paints a really necessary picture. And based on that assessment, what kind of nursing diagnoses might come up?
You might see things like ineffective coping, definitely, disturbed sensory perception, especially in conversion disorder, chronic pain if somatic symptoms are prominent. For DID, disturbed personal identity is key. Anxiety is common across the board, and impaired memory for dissociative amnesia.
Okay, so the diagnoses really target the specific problems the person is facing. What about interventions? What can nurses actively do?
Number one is validating their experience. Saying something like, I understand these symptoms feel very real to you. That builds trust like nothing else. Encouraging them to talk about their feelings, their stressors, is also key, helping them connect emotions and physical feelings or dissociation.
And what about those secondary games you mentioned? How do nurses handle that carefully?
Right. It's about being supportive without unintentionally reinforcing behaviors that might keep someone stuck. So, acknowledging their distress, but gently redirecting focus towards coping skills, function, and expressing feelings, rather than dwelling only on the symptoms. Having consistent staff helps too, building that reliable therapeutic relationship.
That consistency sounds really important for trust. What else?
Teaching those grounding and relaxation techniques we talked about, empowering them with tools, and generally supporting a shift away from endless medical tests once things have been reasonably ruled out towards focusing on emotional health and coping.
And educating the family is a big part of this too, I imagine.
Oh, huge. Helping families understand the mind-body link, that this isn't deliberate behavior. Teaching them maybe how to spot triggers, how to offer support without reinforcing the sick role too much, encouraging everyone towards consistency, structure, and making sure follow-up care happens.
Okay, this is making so much sense. Let's bring it home with that case study, Jamal, the young man with seizures after his brother died. Tell us about that again.
Right. Jamal, 22 years old, starts having seizures after his twin brother's sudden death. All the neurological workups are negative. It points strongly to conversion disorder. The seizures are very real, but they seem tied directly to the immense grief and likely perhaps guilt or trauma around the death.
And the intervention focused on making that link clear.
Exactly. CBT helped him explore the connection between the seizures and those incredibly difficult emotions he couldn't otherwise process. Therapy, plus things like journaling, gave him safer outlets to express that grief and trauma.
And the outcome was positive.
Yes, very encouraging. As he processed the emotions, developed better coping skills, the seizure episode significantly decreased. It's a powerful illustration to address the underlying emotional storm, and the physical manifestation can calm down. That mind-body connection in action.
Wow. It really drives home how intertwined everything is.
Yeah.
So wrapping up this deep dive, what's the single biggest takeaway for everyone listening?
I think it's just recognizing that profound link between our mental state and our physical experience. Emotional pain is real, and it can show up in ways that might surprise us physically or through shifts in our consciousness. And understanding these conditions truly requires empathy, looking beyond just the symptoms to the person's whole experience.
Beautifully put. And hey, if you're listening and feeling that overwhelm we talked about at the start, maybe you are that nursing student, just remember, learning this stuff is tough. It's complex. But you're doing it. You're building this incredible understanding. It takes time. Be kind to yourself. You're gaining tools that will make such a difference. Seriously, you've got this.
Absolutely. And maybe one final thought to chew on. How do our society's views, the stigma around mental health and unexplained physical symptoms, how might that impact someone going through this? Does it make it harder to even ask for help? Something to consider.
That's a really important point. Food for thought, definitely.
Hmm.
Okay, thank you so much for exploring all this with us today. From everyone here at Book Podcasters, take care, keep learning, and we'll catch you on the next deep dive. You really do got this.